So starting off today's overview, let's take a look at the measures that are being retired and added for Measurement Year 2025. In the upcoming season, we say goodbye to several measures and indicators, though none of these should be a surprise, as all of the retirements have been previously communicated by NCQA. Antidepressant medication management is fully retired due to NCQA focusing their measures on other aspects of mental health. Cervical cancer screening, childhood immunization status, and immunizations for adolescents retire their administrative and hybrid reporting versions and will only be reportable via their electronic clinical data systems version going forward. Care for older adults had its pain assessment numerator retired, leaving only two numerators now for medication review and functional status assessment. NCQA will eventually create a pain assessment measure to replace this numerator, but they haven't introduced it with Measurement Year 2025. NCQA has also removed all ICD-9 codes from measure value sets, particularly those with longer look-back periods in the member's history. Eye exam for patients with diabetes got converted to an administrative-only measure, removing the hybrid reporting component. We see quite a heavy hit this year to hybrid reporting, as a third of the hybrid HEDIS measures are no longer hybrid reported, bringing us down to only 8 remaining hybrid measures for 2025. A noteworthy takeaway here for any folks involved in creating samples, some of these hybrid retirements will impact measures that previously could share samples. So lead screening in children will no longer have a shared sample with the retirement of CIS. Also, the diabetes measures will now only have 2 measures that could share a sample, with glycemic status assessment and blood pressure control. Since exchange populations do not report BPD, they will only have 1 hybrid diabetes measure for 2025. Next up, we'll review the 3 new measures added by NCQA for 2025. All of these measures were included in NCQA's public comment period back in February of this year, though they have some changes compared to the versions that were published in the public comment. The first new measure we'll review is blood pressure control for patients with hypertension. This measure was created by NCQA to be the eventual electronic clinical data systems replacement to the hybrid measure controlling high blood pressure, though NCQA has not yet finalized when CBP will officially retire in favor of this measure. BPCE reports on the percentage of members 18 to 85 years old who had a diagnosis of hypertension and whose most recent blood pressure was less than 140/90 during the measurement period. It applies to the commercial, Medicaid, and Medicare product lines. Given that this measure has a lot of similarities to the existing CBP measure, I'll focus on covering components of the measure that differ from CBP, as well as what's changed about the measure since it was posted for public comment. Beginning with the differences from CBP, BPCE is an ECDS measure and does not have a hybrid reporting component. Additionally, NCQA has expanded the event diagnosis criteria for this measure. Eligible members can either have 2 outpatient or telehealth hypertension diagnoses on different dates of service, which matches the existing CBP logic, or the new option of having 1 outpatient or telehealth hypertension diagnosis along with a dispensed antihypertensive medication in the prior year or first 6 months of the measurement year. NCQA originally proposed in the public comment to add a second numerator for blood pressure less than 130/80, but did not move forward with that proposal in the 2025 specs. If you've been in HEDIS a few years, you may recall that having a non-acute inpatient admission in the measurement year used to be an optional exclusion for CBP. When NCQA retired the optional exclusion concept, they moved the non-acute inpatient admission exclusionary criteria into the steps of the event diagnosis criteria, where it is in CBP today. With BPCE, they've simplified the event diagnosis criteria by removing this step and instead shifting it to be a required exclusion. And finally, one of the biggest differences with BPCE is that NCQA tweaked the verbiage around how to select a representative blood pressure if more than 1 blood pressure reading is present on the latest date of service. Instead of using CBP's logic to take the lowest systolic and lowest diastolic readings from that day, BPCE requires that the latest blood pressure reading taken on the day be used. This small shift in words represents a huge change in HEDIS and becomes the first measure now to mandate a time component within the logic. We've been in back and forth communication with NCQA via PCS over this change in the specification from the public comment. At this time, they do seem keen on requiring the time component to take priority here when selecting between multiple blood pressures, insisting that organizations must ensure that all data elements needed for the measure logic are present in their source data. They've also indicated that our logic should prioritize EMR records that contain a time component over other data sources that do not have a time associated. We're still working with them to understand the requirements for selecting a representative blood pressure if none of the sources have time available, as well as to understand the requirements around the specificity of the time component, such as the inclusion of a time zone for the reading. We'll be sure to communicate the requirements as we gain further clarity with our 2025 input specifications documentation. Next, we'll cover NCQA's 2 new mammogram focus measures, which they added to expand upon the current breast cancer screening measure. We'll begin with documented assessment after mammogram. NCQA slightly updated the name of this measure compared to the public comment version, removing the word BI-RADS from the name, though you'll see they kept the letter B for BI-RADS in the measure abbreviation. This measure evaluates the percentage of episodes of mammograms that have been documented in the form of a BI-RADS assessment within 14 days of the mammogram for members 40 to 74 years old, and it applies to all product lines. You may have noticed that NCQA did not add 40 to 49-year-old members to the breast cancer screening measure, which they've considered in prior public comments, but these 2 new mammogram measures do include events for members aged 40 to 49. This is an episode-based measure whose eligible population would be made up of all mammograms between December 18th of the prior year through December 17th of the measurement year. The intake period had a slight adjustment from the public comment version, where it previously started on January 1st of the measurement year. One item that stood out to us from the way the measure was designed is that there's no mention of a negative history or deduplication period when it comes to multiple mammogram events for a member in a close time period. We reached out to NCQA via PCS, and they noted that since a member can have multiple mammograms on the same date of service, the member can have more than one eligible denominator event counted in the eligible population on the same day. We recommend taking an advanced look at the way you're sending mammogram data today for the breast cancer screening measure to evaluate if you have consistency between your data sources for information such as the provider that performed the mammogram and the date that the mammogram occurred, to try to prevent inflation of your DBME eligible population due to source inconsistencies. Members who are deceased or in hospice in the measurement year will have their mammograms excluded. For compliance, the member will need to have a documented BI-RADS score dated on or within 14 days after the eligible mammogram for 15 days total. The value set for reporting BI-RADS scores contains both SNOMED codes as well as a brand new code type called RADLEX Radiology Lexicon. These codes all begin with the letters RID and are followed by numbers. RADLEX codes are a new addition since the public comment for DBME, and they're making their HEDIS debut with these mammogram measures. We recommend reviewing your EMR sources that you have today to see if any of them are able to provide you with RADLEX ID codes to indicate BI-RADS scores for mammograms. In our PCS for NCQA, where we were discussing multiple mammogram events in a short time period, NCQA also indicated that one BI-RADS score can be used to make multiple denominator events compliant within that 15-day window. The final new measure we'll be covering today is follow-up after abnormal mammogram assessment. This measure has also been renamed from the public comment version, replacing the words breast cancer with mammogram, and also getting a new measure abbreviation. The measure evaluates the percentage of episodes of inconclusive or high-risk BI-RADS assessments that received appropriate follow-up within 90 days of the assessment. It also applies to members aged 40 to 74 in the intake period, and the intake period for this measure is October 3rd of the prior year through October 2nd of the measurement year. Similar to DBME, this measure has no deduplication of nearby events. So all eligible BI-RADS assessments can be considered, even those on the same date of service. So a similar takeaway here to DBME We recommend that as you are adding sources for BI-RADS scores with SNOMED and RADLEX codes, ensure you have consistency between your sources for data such as the provider or the date that the BI-RADS was documented to try to prevent inflation of your FMAE eligible population due to source inconsistencies. The measure also excludes events for members who are deceased or in hospice during the measurement year. The compliance criteria differs depending on whether the eligible episode was high risk or inconclusive. For high risk episodes, the event will be compliant if the member receives a breast biopsy on or within 90 days after the BI-RADS assessment. For inconclusive episodes, the event will be compliant if the member receives a mammogram or breast ultrasound on or within 90 days after the BI-RADS assessment. We have a PCS out with NCQA now to understand how to differentiate the mammogram that led to the inconclusive BI-RADS score versus a proper follow-up mammogram, given that the way the numerator is written today allows for mammograms on the same day of the score for compliance. But we haven't yet received a response prior to this presentation. Additionally, NCQA indicated via another PCS response that if a member has evidence of both an inconclusive BI-RADS and a high-risk BI-RADS in close succession, both would be included in the eligible population as separate events, and both would need their proper follow-up care for compliance. Also similar to the PCS response we received for DBME, if you have multiple eligible denominator events in close succession from the same risk category for a member, such as multiple high-risk BI-RADS assessments, a single breast biopsy can be used to make multiple denominator events compliant within the 91-day window. Now we'll move on to the changes to existing HEDIS measures for measurement year 2025. Overall, many measures have no changes in the specification, with over 40 measures noted as unchanged for 2025. Additionally, several measures with changes are still only minor changes, so we should see a good amount of consistency between 2024 and 2025 from a measure requirements perspective. Now let's dive into the measures that did have notable changes for 2025. Beginning with the updates NCQA has made toward their mission of improving health equity. In the realm of race and ethnicity measure reporting, NCQA moved forward with their public comment proposal to take away the direct and indirect source stratifications from measures with race and ethnicity stratifications for 2025. This accounts for a 58% decrease in IDSS reportable data elements for race and ethnicity stratifications, while still giving insight into any potential racial or ethnic disparities in care. Even though the sources are no longer reported within the race and ethnicity stratifications, they are still present as part of the reporting for race, ethnicity, diversity of membership. With the RDM measure, NCQA made several updates to the naming conventions of these data sources. Health Plan Direct is now called Health Plan Collected. The CMS and state databases option is now replaced with a source called Enrollment Files, opening it up to other sources of race data, such as employer enrollment files. The indirect source category has been rebranded to now be called Imputed Source. A brand new source type has been added called Unknown, not to be confused with the previous unknown source type. This new unknown source is to be used if you have legacy, race, or ethnicity data that you do not know the origins of, to be able to properly attribute it to a direct or imputed source. This is not the same as the unknown category from prior seasons. The previous unknown category has been renamed to no data, and that's the one you should use if the race or ethnicity is unknown for a member. We recommend reviewing the changes to the race and ethnicity stratification general guideline, as well as the RDM measure source types, to begin evaluating if your race and ethnicity data source mappings may need some updates for 2025. In the gender inclusivity space, NCQA moved forward with their public comment recommendation to update the chlamydia screening measure. The measure has been renamed to just chlamydia screening, dropping the phrase in women from the end. This differs from the public comment proposed name that it had added in adolescents and adults to the end of the measure. NCQA utilized the same eligibility criteria as breast cancer and cervical cancer screening, So eligible members will be identified by either an administrative gender of female in the member's history, sex assigned at birth of female in the member's history, or sex parameter for clinical use of female typical in the measurement year. Note that the public comment proposed version of CHL had a different time frame for sex parameter for clinical use than the other screening measures, but the final 2025 measure was updated to be consistent with the other screening measures. Similar to cervical cancer screening, CHL now also has an exclusion for sex assigned at birth of male in the member's history. Public comment version of CHL had added criteria for male members with vaginoplasty in both the eligible population and exclusion criteria, but those components have been removed from the final version of the measure. NCQA also removed the gender stratifications from risk measures. So now acute hospital utilization, emergency department utilization, and hospitalization for potentially preventable complications will report their rates stratified by age only, not age and gender. NCQA notes that the risk weight models still have gender incorporated, only the measure stratifications will be affected. Several of the immunization-related ECDS measures have notable changes for 2025. Adult immunization status has the most sweeping changes, most of which were documented within the public comment version of the measure earlier this year. NCQA finalized the age stratification changes for the influenza, TD-Tdap, and zoster indicators, moving 65-year-olds from the lower age bucket to the higher age bucket. Zoster also finalized the removal of the single-dose live vaccine for compliance. A new change that was not included in the public comment version of the measure is that the minimum date for the zoster 2-dose vaccine series has been changed from the member's 50th birthday to now instead be a hard date of October 1st, 2017 for all members. The pneumococcal numerator finalized the change from the public comment to add 65-year-olds to it. NCQA also proceeded with adding the proposed hepatitis B numerator to the measure for 19 to 59-year-olds. They kept their proposed numerator options for 3 doses of the childhood vaccine, 2 to 3 doses of the adult vaccine, and anaphylaxis due to the hepatitis B vaccine. But newly added since the public comment, they added a history of hepatitis B illness. NCQA also revised the numerator criteria pertaining to having hepatitis B pre-vaccination testing from the public comment version of the measure. There are now 2 different testing options. One's for a pre-vaccination test with a corresponding code that represents an immunity finding. The other is for hepatitis B tests with a threshold of 10, which also requires an associated numeric test result value that is greater than 10. We recommend that when you're looking at data sources for hepatitis B compliance, you ensure that the numeric result values are provided along codes with this value set to ensure that they count for compliance. We also reached out to NCQA as we noted that AISE was not added to the list of measures in the general guideline for collecting data for measures with multiple numerator events, which is the general guideline that requires all numerator events to be at least 14 days apart to prevent double counting of events. We asked them if this was intended or not, given that there are a lot of parallels between this numerator and the CISE hepatitis B numerator, and CISE is included in that general guideline. Their initial response was that AISE was intentionally not included in the general guideline. However, after we sent some further questions, they took this as a takeaway item to evaluate internally for a potential change in a future version of Volume 2. Childhood and adolescent immunization measures each also had some minor adjustments. CISE has a newly added exclusion option for children that have received organ or bone marrow transplants on or before their 2nd birthday. IMAE has expanded the compliant age range for the meningococcal numerator. The minimum age for this vaccine is now 10 instead of 11 for 2025. Next up, we have the changes incoming for the mental health follow-up measures for follow-up after hospitalization for mental illness and follow-up after emergency department visit for mental illness. NCQA proposed most of these changes as part of this year's public comment period and has finalized them into the specification. Both measures have an update to their event diagnosis criteria to allow intentional self-harm diagnoses in any position, not just the principal position. They also finalized adding several new diagnoses to the eligibility criteria, including phobia, anxiety, and additional intentional self-harm diagnoses. Members in residential treatment facilities will no longer be excluded, and these services are now considered numerator compliant. Both measures also added new numerator options for peer support and transitional care management services. One notable difference compared to the public comment version is that NCQA did not move forward with adding the proposed occupational therapy numerator options to either measure. The FUH measure has several new numerator options to allow for visits with any provider, as long as they have a diagnosis in any position of mental health disorder. The FUM measure also has many additional numerator adjustments, including a change to the requirement for mental health diagnoses to now be in any diagnosis position, not just the principal. They removed the mental health diagnosis requirement entirely from the numerator options for electroconvulsive therapy, community mental health center, and partial hospitalization or intensive outpatient event. They added new numerator options for psychiatric collaborative care management and visits in a behavioral health care setting. They also cleaned up the numerator options that required a principal diagnosis of intentional self-harm with any diagnosis of mental health disorder, as these are now overlapping with the existing numerator options for any diagnosis of mental health disorder. To wrap up some of the other noteworthy measure changes for 2025, the acute hospital utilization measure finalized the proposed change to add the Medicaid product line for reporting. This product line will have an upper age limit of 64, compared to the commercial and Medicare product lines, which report on 65 and older as well. Similar to the plan all-cause readmissions measure, Medicaid members who are dual enrolled in commercial or Medicare plans will be excluded from Medicaid reporting. Members will be excluded as outliers from Medicaid reporting if they have 6 or more discharges in the measurement year, which is a higher outlier threshold than other product lines. In addition to the change mentioned at the beginning of this presentation, where eye exam for patients with diabetes removed a hybrid reporting component, NCQA also added new left and right eye retinopathy compliance options, some of which make use of LOINC answer codes. This will be the third application of LOINC answer codes in HEDIS, previously just used for social needs screenings and sex assigned at birth. We recommend evaluating your EMR data sources for the presence of retinopathy-related LOINC answer codes so you can utilize them for HEDIS reporting. NCQA also moved the criteria for eye enucleation from being numerator events to required exclusions. The use of imaging studies for low back pain measure has gotten NCQA's simplification treatment, as they've removed the visit setting type requirement from the event diagnosis criteria. This measure also has a new required exclusion for a diagnosis of osteoporosis. The two statin therapy measures for cardiovascular disease and diabetes have a new required exclusion as well for muscular reaction to statins. NCQA also finalized the change that they noted during the public comment period, that telehealth events are no longer considered compliant for the well-child utilization measures. Yeah. So today we reviewed the changes that have been finalized for measurement year 2025 with the recently published Volume 2 documentation from NCQA. We covered the retirements and newly added measures, as well as several key measure changes for the upcoming season. Throughout, we noted several recommended takeaways for you and your teams to get an early start at preparing your data for the new season so you can set yourself up for success.